All right. Hello to everybody. Thank you for joining us today. Welcome to the second session of Preemption 101 and why it's important for Prenatal-to-3 advocates. I'm Ali Rahimi, National Grassroots Manager Digital for Voices for Healthy Kids. I provide technical assistance and support to campaigns in digital grassroots and look forward to meeting those on the call that I haven't met yet. And I'm joining you today from unfortunately cloudy Dallas, Texas. As you join, please introduce yourself with your name, organization, and location using the chat. We can go to the next slide. So we have some housekeeping items today. First off, today's call is being recorded. We'll be sure to share the recording, slides, and any tools or resources that we reference after the call. If you need assistance during the call, please message tech support in the chat. We will have a Q&A session at the end, but please feel free to put your questions in the chat box as they come up during the session so that we can address them. If we don't get to all of the questions or don't have an answer to your question, we'll be sure to follow up after the call. We ask that you please keep yourself on mute when not speaking to allow others to best hear. We do have closed captioning available during this meeting. You can enable that in your Zoom toolbar. At the end of the session, we'll share a brief survey that should take just a couple of minutes to complete. We'll even try to end 2 minutes early so that you have time on the call to do that. We really do value your feedback and take it seriously, and it will help make this series and our future offerings better. We ask that all participants have respect and allow grace for one another today. Please experience this training how you learn best and let me know if there's anything I can do. And again, if you haven't already done so, please introduce yourself in the chat box with your name, organization, and location. And welcome to all. Next slide. So across the United States, local governments have developed and implemented innovative solutions to improve their communities, such as smoke-free laws, paid sick leave policies, and increases in minimum wage. However, states are increasingly passing abusive preemption laws that limit or even eliminate the power of local governments to enact policies in these areas. This type of preemption can perpetuate disparities in health and equity. Today, we're going to review the science behind preemption and how preemption can impact the health and well-being of communities. We'll also hear from the experience of Philadelphia in using local policy to support increased services to children and families in their city. We'll also examine the risks preemption posed to them and to other cities looking for revenue streams to support community wants and needs. We will have time for Q&A and to review the tools and resources available. I will now turn it over to my colleague, Dr. Stephanie Scarmo, to introduce our first guest.
Thanks, Elaine. Hello, everyone. I'm Stephanie Scarmo, the National Senior Director of Policy Research for Voices for Healthy Kids. I oversee the policy development, research technical assistance, and evaluation efforts for the initiative. Today, I have the pleasure of introducing Dr. Douglas Wolfe. Dr. Wolfe is a demographer, policy analyst, and gerontological researcher who focuses on the economic and social aspects of aging, disability, and long-term care. Dr. Wolfe's professional experience includes an appointment as an economist in the Office of Income Security of Health, Education, and Welfare, now DHHS, several years at the Urban Institute, culminating in a position as a director of its Population Studies Center, and several years at Syracuse University, where he is currently a research professor of aging studies. Dr. Wolfe is also an author on the 2021 study many of us have read, titled The Effects of U.S. State Preemption Laws on Infant Mortality. Welcome, Dr. Wolfe, and I will now turn it over to you.
Okay, well, thank you very much for the introduction and for inviting me to present. Now, can you switch over to my PowerPoint presentation? Okay. I just want to very quickly acknowledge the support for our research that came from the Robert Wood Johnson Foundation and also my collaborators on this project, Shannon Monnet and Jennifer Harris Montez, both of whom are also here at Syracuse. The title I picked, we're hearing a lot about weaponization as some horrible thing that government is doing to its citizens. And I thought I'd turn that around a little bit and talk about preemption as a manifestation of weaponization of state legislatures. Next slide, please. Ollie's introduction actually covered a lot of what my first few slides say, so I'll go quickly rather than be repetitive. And preemption, as we've heard, is any law passed by a higher level government, which can be the federal government or a state government, that restricts the authority or capacity for a lower level government to make policy changes. So next, the preemption is not necessarily a bad thing, and it's been around for forever, really. I mean, it goes back to the founding of the Republic in one way or another. But as Ali mentioned, it's been increasingly used to thwart progressive policy and initiatives, although it can be used to establish floors or minimums that would promote public well-being, as well as to establish ceilings or take preventative steps that stand in the way of progressive initiatives. And some laws actually have both a floor and a ceiling aspect to them. That's especially the case in paid sick leave legislation. Next. I'll just, again, a bit repetitive. In recent years, there's been an explosion of preemptive legislation at the state level aimed at a very wide variety of policy domains, such as tobacco use, food labeling, land use, public broadband access, and several others. And if we go quickly through the next several slides, I've just got maps that show which states have done which things. So here's states that have adopted inclusionary zoning preemption, municipal broadband access, rent control, transgender rights. And if you can linger on this one for a second, from this point on, I'm going to be talking about minimum wage mainly, and paid sick leave secondarily. And this map shows which states have done one or the other or both. And if you noticed through that series of slides, there's a bit of a geographic theme there. There's the South and the Midwest are most strongly on the preemption bandwagon. So next, please. I'm going to summarize some of the findings from the paper that was already mentioned, the study on minimum wage and infant mortality. And we have a second paper that deals with adult mortality, and we looked at specific causes of death, suicide, homicide, drug overdose, and a few others. And in that second study, we mainly ended up focusing on paid sick leave because that had the strongest effect. But I'm going to mainly talk about the minimum wage study or minimum wage preemption as it relates to infant mortality. Now, this webinar was advertised as one in which there will be a review of the data research on preemption. And I will confess, I'm going to be focusing almost exclusively on our own work, but I haven't seen many, and at the moment I can't think of any studies other than our own that have actually tried to quantify, but in numerical terms, the public health consequences of preemption law. And you'll see what I mean in a few slides. Both of the papers that I'm going to talk about took a two-part approach. In the first part, we used more or less straightforward statistical techniques to try to isolate the effect of one or the other policy domain, either minimum wages or paid sick leave provisions or requirements, on a mortality outcome. There's a large literature in economics and health economics, other domains, that tries to determine the effect of policy initiatives, policy interventions on health outcomes of various sorts. And there's been lots of work on what minimum wages do for workers, their families, for employers, for communities, and so on. There's lots of work on what paid sick leave laws do, but very little work has taken that extra step of saying, okay, what happens when you preempt places from raising the minimum wage? So in the second stage, or the second part of our two-part analysis, we try to calculate just what difference it makes to adopt a preemption law, what difference it makes in the places that have been prevented from taking the progressive step that they wanted to take. So next, please. So what we found in part one, and this is very high level summary here. By the way, if it's not already there, my email address is going to be in the chat room for this webinar. And anyone who would like a copy of either or both of these papers, please just email me. They're both open access, but I'm happy to just provide you with a PDF. Anyway, for the infant mortality paper, what we found is a $1 increase in a minimum wage produces a 1.5 to 1.8% reduction in the infant mortality rate. And I have to say, we only found this in metropolitan area counties. The analysis was done at the county level, and it covered 20 years of data. So we had a very, very large data set to look at. And we, in addition to taking account of what states set up as their minimum wage, we looked at all the places where counties and cities have gone beyond what the state minimum is and gone even further. And there's a lot of cities in California that have gone above California's minimum wage, and there are others here and there around the country that have gone beyond the state minimum. We accounted for all that, and in particular, what we're going to end up with is showing for this local areas, the counties and cities where they tried to go above the state minimum, but preemption kept them from doing that. That's where we're going to get our so-called preemption effect. So next slide, please. So in the second part of our analysis, we looked at what we called the known counterfactuals. In this kind of policy evaluation work, it's generally the case that you really don't know what the world would have been like in the absence of a policy. But in the case of minimum wage preemption, we are in the remarkable position of being able to point to individual counties where they tried to raise the minimum wage, and we know what minimum wage they tried to establish before the state turned around and preempted or prevented that from happening. So we can actually calculate what the world would have looked like in the absence of preemption. And in this case, what we're doing is we're calculating the number of infant deaths that would have been expected had these places been able to raise the minimum wage as they wanted to. And I've listed at the bottom of the slide the 9 metropolitan counties where we actually know what they tried to do, what they were prevented from doing. We know how many infant deaths actually happened, and we're able to calculate how many infant deaths would have happened if they'd been allowed to raise the minimum wage. Now, the numbers are going to look small, but I think that from a public health perspective, they're actually quite meaningful and important. So for these 9 counties, we calculate that in 2018, there were in fact 493 infant deaths. If they had been allowed to implement the minimum wage law that they passed, in other words, if preemption hadn't been in the way, the number of deaths in those same nine counties would have dropped to 468. Okay, 25 deaths attributable to preemption. This is about 5% of observed deaths. I think most public health officials would be thrilled to think that there's a tool in their toolbox that could lower their death rate by 5%. And if you try to turn it into monetary terms, the way the US OMB, Office of Management and Budget, when they're doing cost benefit analysis of proposed legislation, according to standing regulatory practice, it's a nearly $10 million per person. You value a life saved. Well, for these 25 deaths, that adds up to over $240 million. Once again, I would think public health officials would be thrilled to think they could save $240 million in costs, public costs. And to really push this a little further, and this is just my fanciful policy wonk hat speaking here, I've tried to ponder the possibility of actually charging a state legislature with wrongful death. Because when they passed these preemption laws, it's possible to establish, I think on pretty good grounds, a statistical case for them having caused deaths to happen. The problem is you can't tell which deaths to be attributed to the preemption law. So you don't really have the person bringing the lawsuit would be, you wouldn't know on whose behalf it would be. So I got one last thing I want to talk about. If you go to the next slide, I think you will not be surprised to learn that there is a racial dimension to all this. And I'm going to illustrate this with one case study of what happened in Alabama. In 2016, the Montgomery City Council passed an ordinance requiring a $10.10 per hour minimum wage. The state of Alabama doesn't have a minimum wage at all. It's required by federal law to use the federal minimum wage, which I believe is $5.65 an hour now. It's not very much. So this would have been a substantial increase for the people who work in Montgomery, Alabama. But within days, the Alabama state legislature passed a preemption law that blocked this law from going into effect, preempted that city, its county, and all other parts of Alabama from ever raising the minimum wage above, well, to any level, actually. If you go to the next slide, there is, without doubt, a partisan nature to the vote for that preemption law. And you can see the Republicans in both the House and the Senate were almost uniformly in favor. The Democrats in both the House and Senate were almost uniformly opposed. And the last slide, next slide, there's a racial aspect to party affiliation in the state of Alabama as well. You can see that the people self-identified as white are overwhelmingly Republican. People who are identified as Black are overwhelmingly Democrat. So you can connect the dots pretty well here between the interests served by the preemption legislation, the interests harmed by the preemption legislation, and basically who's responsible for it. So that's all I have to present. And I know that part of the reason for having this series is to develop tools for advocacy. And I think that the strongest case I can make here from an advocate's point of view is that there's numbers backed up by pretty good statistical techniques to inform legislators, policy analysts, think tank type people and help make the case that preemption is harmful. It has public costs, and that there's a strong inequity element to how those costs are distributed. So I look forward to your questions.
Thank you so much, Dr. Wolf. The research and data are so compelling and really complete the story about why abusive preemption policies are a threat to the Prenatal-to-3 movement and equity. We will be back to you with questions soon, but now I'm excited to turn over to Dan O'Brien and Shirley Howe from Children's First PA. Children First PA was a critical member of the coalition that fought for and passed a sugary drink tax in Philadelphia that has, among other things, funded free pre-K for more than 10,000 kids in the city. They have managed to fight off many preemption threats and offer some important lessons to other municipalities looking to save potential funding streams from preemption. Dan and Shirley, I will now turn it to you.
Great, thanks so much. I'm Shirley Howe with Children First. We're a child advocacy organization in Philadelphia, Pennsylvania. And I'm just here to provide a case study of a policy that we pushed in the city of Philadelphia City Council with the inauguration of a new mayor all the way back in 2016. I thought the best way to go about it would just to kind of timeline the sequence of events that led to us passing the first major city to pass soda tax. Is shorthand that we use. I know it's beverage tax, sugary drinks tax, but in Philly, we just call it the Philly soda tax. Back in 2016, Mayor Kenny was a new mayor. It was his first term. It was the start of his first term. Shortly thereafter, less than 3 months later, he proposed his signature piece of legislation, the Philadelphia soda tax. Almost immediately after, lightning fast, two coalitions were formed, one in favor of the Philly soda tax and one opposed. It included, so they're clever names for both, so I'll mention them. We worked on Philadelphians for a Fair Future, PFF, and it included unions, Philadelphia Parks Alliance, Public Citizens for Children and Youth, which was our former name prior to Children First, civic organizations, labor unions, private companies, health experts. Mayor Michael Bloomberg funded in large part our efforts. There were over 80 groups involved in that coalition. On the other side of the argument was Axe the Philly Bev Tax. Big Soda, concerned citizens, business owners, restaurants, the Teamsters Union were among the members of that organization. Spent lots of money on an advertising campaign throughout the next 3 or 4 months when it was being debated in City Hall. So as a child advocacy organization, we had built relationships with childcare providers throughout the city of Philadelphia, and we asked them to come fight with us. And some of the news reports at the time, we were called the secret sauce of the success of Philadelphians for fair future. So many of these childcare providers that we had built relationships with came and helped us at city council meetings. We went prior to city council hearings. We brought dozens of pre-K students into council hearings, which is a feat in and of itself. We had press conferences outside City Hall. Many of the, all of the providers that were involved in this advocacy, I'll mention, were not necessarily going to benefit directly. They weren't Philadelphia pre-K sites. We were just fighting for its adoption. So they were on board with us from the very beginning. And then so shortly thereafter in June 2016, as government moves, it was fairly lightning fast. So within 6 months, new mayor in Philadelphia, signature piece of legislation, lots of advocacy and coalitions built on either side of the Philly soda tax fight. We get it passed in city council. So directly thereafter, and where the connection comes in here is, so bills were proposed at the PA General Assembly in Harrisburg, our capital in Pennsylvania, very quickly. A lawsuit was filed. So it was kind of on hold for probably the next 2 years. The court decision that we ultimately won at the PA Supreme Court level was decided in July of 2018. So although revenues had been collected starting in January of 2017, we really didn't start to put plans in motion for spending that money on Philly pre-K until after the court decision. So we're constantly, especially in the early years, kind of looking over our shoulders about other preemption laws being filed in the PA legislature. What the professor said about weaponizing your Pennsylvania legislature. I don't know. I know I've seen many people from all across the country so our dynamic in Pennsylvania, Harrisburg is our capital, Philadelphia is the major city in Pennsylvania. We don't always, it's somewhat of an adversarial relationship. So we were looking to Harrisburg and looking over our shoulder to Harrisburg quite often during these early years of the soda tax. So just some general themes, we stayed in our lane. We worked with the constituencies that we had relationships with, and those were the childcare providers, the families, and the kids. It was really important to our work in getting the soda tax passed. A key strategy of the county administration, in addition to working with Philadelphians for a Fair Future, was to get it over the finish line. We did, it wasn't over there. And then, so moving forward, looking at some of the numbers, and Dan, I'll pass it over to Dan to talk about some of our continued advocacy, because 2016, 2018, especially throw a pandemic in the middle of it, seems like a long time ago. But in Philadelphia, it's something that families have come to rely on. Philadelphia pre-K is offered at over 180 sites, and those are sites throughout the city. In all neighborhoods. We're a major city, the largest in Pennsylvania. So it's a big deal. Children must be 3 or 4 by September 1st of the upcoming school year. There are no income requirements for the program, and it's free to families. So we've served, I know it was mentioned before, but over 10,000 children have been served. Those moving on to the K-12 system has served them well as a foundation for their early learning. And also, I'm getting stuck. Oh, money. So over from 2017, when revenues were first started to be collected, until the fourth quarter of 2022, the soda tax has raised over $409 million, 38.6% of that going towards Philly pre-K. In addition to Philly pre-K, money goes to community schools, and efforts to improve parks, libraries, and recreation centers through a program that we call Rebuild. Other money goes there, in addition to going to the program administration for some of the city services that provide, who do all the work behind the scenes on all programs. So I'll pass it over to Dan just to talk a little bit about how we've continued efforts to kind of shine a light on what we've done in Philadelphia, how many kids it's benefited in the families, and so some of our advocacy chops examples.
Thank you, Shirley. Yeah, thank you. So Shirley kind of mentioned how, kind of gave you a timeline for the process of getting it passed, all the stakeholders that were involved, and how it kind of moved fairly quickly through the city, but obviously hit a lot of snags when it came to the state level. And really what a lot of that has to do with, and Shirley kind of alluded to this, is that in Pennsylvania, Philadelphia is kind of looked, as this outside place where, the rest of Pennsylvania, for the most part, whenever they hear Philadelphia, it's almost like, no, stay away from that. We don't want to do what Philadelphia is doing because it's a much more, they believe, like a much more liberal area. It doesn't match up with the rest of the state. So whenever you hear Philadelphia, usually there's going to be political attacks that come down from it. So really what ended up happening is, and a real good lesson learned, is that the fight is not over after the win, the quote unquote win. It's important to always keep advocating because, new things change. For instance, a lot of the folks that were spending a lot of money against getting this soda tax implemented in Philadelphia are currently running for mayor of Philadelphia or are supporting candidates for mayor. And what has been proven, I think, is due to the success of this program, they have been less eager to publicly go against it. It's almost the idea of, the Affordable Care Act. You get it passed, and then obviously it might not be perfect at first. So you continue to have to advocate for it, continue to have to improve it. But once you have something passed, it's much harder to take away. And I feel like due to some really good publicity and awareness campaigns, that we have gotten to a point in Philadelphia where somebody is not going to run on taking something away that benefits kids and families. So it's very important. And Shirley mentioned how it was a priority of the mayor early on in his term. But one thing that she left out is that the mayor's office, including the mayor, always aren't the best PR people. So, when it comes to charisma or dedication to doing these events that really draw awareness to the success of a program, that's where we came in. We tried to, show the benefits and have like kids involved and, creating artwork and sending it to city council members. We organized these events where we would take the mayor around to pre-K sites around the city to try to get good press for these events. And the reason why we did this is because, as the professor was talking about, the research is so important to proving kind of what we do at Children First and what advocacy organizations do, because we use research to then prove what we are saying anecdotally through press, to legislators, to lawmakers, and it's hugely connected. And so one of the main things that we have to do is just never stop advocating. There were some snags that happened immediately after the program, was created and implemented. That's where we come in to make sure that it's, the folks that are running it right. So it actually benefits the people that, were meant to benefit when a law was passed. So there's a lot of ways that you can use research. There's a lot of ways that you can use advocacy. You can use media attention to ensure that a program that you get implemented does not go away the next time a new administration comes in or the next wave of political conversation comes in. So really what I think I'll leave with you is that just because you get the win doesn't mean that the fight is over. And research and evidence of proving why something is successful and finding those anecdotal stories and connecting them all together is so critical to ensuring that great programs that benefit kids continue and then also continue to be approved upon. So I'll leave it there, and then I guess we are going to be opening it up to questions.
I think we were waiting on Laura, but I'm happy to jump in here. This is Allison. If you have questions, it would be great if you want to just hop off mute and ask them, but I do have one here. It says to Dr. Wolf, can you speak to why we only see a minimum wage impact in metro area counties? Or was it simply that those were the only counties that had significantly increased the minimum wage? Also, we see a leveling off of minimum wage impact on infant mortality, or is it the impact the same regardless of minimum wage?
Okay, well, thank you very much for that question. The questions, let's say. The first part is, well, there's really two aspects to the question. It's what's the size of the impact in metro versus other counties? And is that, given that size, is that a statistically significant impact, yes or no? And I don't think I can give a definitive answer to the question. But it's not that it was only metro areas that raised the minimum wage, because I mentioned that we had a two-part analysis. Part one looks at the effect of the minimum wage on infant mortality, and that's where your question rests. But that covers all jurisdictions, all counties, large and small. Now, metro counties are about 25% of all counties, but they're over 50% of the population. So they count more in the analysis. They get more weight. And so a given size of effect is more meaningful in the metro counties than in the rural counties. But it's not just purely statistical differences, because the the capacity for a minimum wage increase to reduce infant mortality is going to depend partly on the nature of the employment in a given area, partly on how high the infant mortality rate already is in a given area. And these, I'm not trying to hide here behind the blizzard of numbers, but there are several possible explanations. I'm looking at the paper here. The infant mortality rates actually tend to be higher in rural areas than in metro areas. So there's more potential to bring things down where their rates are higher than when they're lower. On the other hand, and this is kind of speculation on my part, I suspect that the service industry, retail, fast food, and so on, sectors of the economy that in which minimum wages are most prevalent are also most common. They're more common in urban than in rural areas. So there's more chance for their minimum wage to actually make a difference in people's wages in urban areas than in rural areas. So, like I say, I'm not trying to hide here behind facts, but there's several possible explanations, and I can't give a definitive answer to what matters the most. If you look at the paper, and I'm happy, like I said, happy to share the paper, the size of the minimum wage change, minimum wage impact on infant mortality is remarkably similar across all county types, large metro, small town, rural, and so on. So it's mostly the statistical significance question that's making the difference. I can't answer your other question because we didn't look to see if there were nuances like a leveling off, like you say, or just a straight line, the more is the better. The approach we took implies that the more you raise the wage, the better off you'll be, but we didn't test for whether basically the result bends, or curves down at some point. So, wish I could be more authoritative on this, but it's a great question and only a partial answer.
That was great, Dr. Wolf. Other questions? Oh, Logan, I see your hand is up.
Hi, great presentations, and this one is for Dr. Wolf again. Was it 210 million or 240 million? Was that cost to the? I know you talked about a value of life at about 10 million, but was that 200 and some million in the healthcare system costs? That was just general life valuation.
That's yeah, you're right. The answer is yes. It's the guideline for how to value it. If someone proposes legislation like raise taxes or prohibit fracking or any of the other policy interventions you might think of, any change in policy is going to produce some cost and some benefits. And often it's easier to quantify the costs than the benefits. So if you can save a life, or if you can project that you'll save lives through a policy intervention, then the question is, well, what kind of monetary value should we assign to a saved life? So that's what the 9.6 million refers to in the calculation I showed you. So when I said that 25 lives were saved, or 25 lives would have been saved in the absence of preemption, it's kind of an abstract valuation of the lives that would have been saved or that were lost. And it's not an actual monetary cost borne by the healthcare sector or even by society in general. It's more of an abstraction.
But yeah, that's really helpful. And when we were trying to protect building codes in Pennsylvania, which is preempted at the state level, and to push for them to adopt better building codes, we used a lot of analysis of poor indoor air quality leading to adverse health impacts on usually young or older people, and the cost to our society based on that. So, and I think it had a really good impact on legislators. So, yeah, this is really helpful. Thank you.
Good, thank you.
We'd love for you to come and speak to our Pennsylvania coalition about this.
Oh, well, maybe we can do that. I lived in Philadelphia for a long time. I got connections.
Great. Other questions? Well, as we think about the stories from Pennsylvania and we look over the study, we may have more, but we know how to reach our esteemed presenters. So I think I turn it over to Ali at this point.
Thanks, Allison, and thank you to all of our wonderful speakers for joining us today and sharing their informative insight on preemption. We hope that you all got a great deal out of today's session and that you plan on joining us for the third and final session in the series, Advocating on Preemption, Where to Start and What to Say, which will be held on April 4th. We also encourage you to spread the word and invite folks from your networks whom you think would benefit from this series. And remember, if you need assistance in your campaigns, please visit our technical assistance portal and we will be in touch soon. In the chat, you'll find a link to the survey that I mentioned at the beginning of the call. You can also access the survey by using your phone to scan the QR code on the slide. Again, your feedback is critical for us to deliver the best training possible. So please just take 2 minutes or so to fill that out now. And thank you all for joining us today. Please reach out if we can offer any additional assistance.